very warm good morning to all of you on this Sunday. I would like to start with thanking 49 and Dr. Jyoti for inviting me here and giving this opportunity to talk about a topic very close to my heart, about fertility preservation. I'm also a founder and executive member of Fertility Preservation Society of India, and I would really love it if some of you take the initiative and join the society and learn from all of us and together what is new in fertility happening in India. So we'll talk about the new age of fertility preservation, and we know that we preserve fertility, either the gametes or the tissue, because patients might be going for treatment which may affect their fertility, and that's the reason why women were initiated into fertility preservation. Of course, one is cancer therapy, second is a non-oncological reason as well. The issue is, in the past 2 decades, the advancements of early cancer diagnosis and treatments have led to around an 80% 5-year survival of these patients. But when they survive, the question is about quality of their life, and that becomes a main issue here, because oncology treatment would require extensive chemotherapy, and this will affect their fertility. There are multiple pathways by which fertility can be affected. We know it interferes with DNA replication and cell division. It activates massively the primordial follicles, causes stromal atresia, and damages the vascularity in the ovaries. In fact, radiation as small as 2 GeV can destroy around 50% of the primordial follicles. And this causes a decrease in reproductive capacity. Of course, it's affected by age, different conditions, syndromes, etc. But fertility preservation has been recognized by ASCO as the basic right of any patient being handed the diagnosis of cancer, and it is our responsibility to guide them and counsel them to understand what are their options and make sure that at some point this is documented, so that tomorrow the patient can look back and say, okay, I had the option, I took a decision which was right for me. There will be around 100 million women at risk of chemotherapy-induced ovarian impairment by this year. This tells us how big is the problem statement. When we talk about fertility preservation, of course, one is medical fertility preservation for oncology patients, for patients of endometriosis, early diagnosed Turner syndrome, autoimmune disorders, and those patients of transplant. Many people don't know this, but if you do a hematopoietic stem cell transplant, patients who are undergoing this are very high risk of developing ovarian and testicular failures. The second part, as the introducer just said, is about social fertility preservation, where women would want to delay their conception and to fight the age-related decline in fertility. So social freezing, we know that age, according to age, fertility declines, and this is what helps patients to understand whether they want to do delayed childbearing. Something called as age banking, where you bank your oocytes for anticipated gamete exhaustion. Age-related aneuploidies can lead to failure in implantation, miscarriages, and chromosomal syndromes. And for those women who wish to delay conception but are very keen for having a biological child, social freezing becomes a norm. So we see in different ethnicity, the change, decline in fertility is very, very prominent. Is there a pointer? No worries. So if you can see these graphs, you will see in each of these ethnic women population, you will see a decline in fertility. And this is because of multiple reasons. One is there is follicular atresia, and by the age of mid-40s and 50s, the eggs and ovaries are completely depleted by this time. There was a multivariate regression analysis which was done between Indian population and Spanish population, and they realized that Indian population is aging 6.3 years faster than the Spanish population. So when you read about Western data, please correct it for Indian information also, because we probably need to be talking to our women more about this than ever before. Because of the widespread use of oocyte preservation, and it has been deemed can't even think about a time when oocyte freezing was just considered experimental. But since 2012, ASHRM has removed the experimental label, and it is shifted, the terminology has shifted to calling it planned oocyte cryopreservation. And the use of frozen egg freezing in United States has jumped up. But look at the Indian data also. It's zoomed up so much, where this is a latest data in October from 2025. And there has been a boom in the market of egg freezing, embryo banking. And Google Trends show that search for egg freezing in India have risen by around 150% in the last year, with, of course, the major traction in the big metropolises. But the problem with social egg freezing is how many people come back to claim those eggs frozen. So Jennifer et al. Reported that the use of eggs was around 38%, and no use rate was around 58% for this population. So they might be freezing, but not everybody is coming back to use it. When we talk about using for social egg freezing, it could be because of their need to shape their family planning. And that has a positive connotation on the patient's, this one, right? This is, this, no? And it is becoming very, very important in society and in politics, and this is being discussed a lot, but we have to keep in mind the psychological variables also for these patients. So there was a study done to see who freezes eggs and why, and they realized that main patients who were using it for these indications were the ones who were having a positive effect on this. But the patients, when they were using it for these two reasons, this is where it was negatively associated. One thing very important to understand, as per a very interesting writer by Camilla Cavendish in Financial Times, is to understand that each egg is not an embryo, each embryo is not a pregnancy. So frozen eggs do not automatically translate to embryos or pregnancy. Coming to medically indicated egg freezing, we know about non-oncological reasons like autoimmune disorders, hematopoietic stem cell transplant, male disorders, and diseases, all of these. The special ones are autoimmune, which we think about. Method of fertility preservation for women are very clear: oocyte preservation, oocyte tissue preservation, GnRH antagonist, and ovarian transposition. For men, it is little bit lesser choices. But this is a simple algorithm for men, that if there are prepubertal, then there will be only a biopsy, and that immature protocol is to be used. For pubertal, those who can produce sperm, they will be frozen for that purpose. And those patients who cannot may undergo TACI to get the sperms and freeze them. So sperm preservation, it should always be repeat visits, multiple samples to make sure that we have sufficient, and surgical procedures should occur before the therapy, around 6 to 12 months after the completion of therapy. There will be azoospermia for these patients as well. Evidence suggests that any kind of anti-neoplastic radiation therapy can cause significant genetic damage. In fact, as early as within 1 to 2 weeks of initiation of therapy, and hence let them freeze their sperm before the therapy is started. There is information that topoisomerase 2 inhibitors, etc., will pose greatest damage between weeks 5 and 7, and nucleoside analogs between 7 to 10 weeks of therapy. For women, the algorithm is slightly more complex. We have to think and decide whether you have time or not, and if you can get the mature eggs and freeze those, that's the best way. If she is in a relationship or a stable marriage, then it will be an embryo freezing. For patients where we do not have that kind of time, option of ovarian tissue freezing is also available. If you look at this chart, I know it's a little highly populated, but I'll point it out what you need to see. Between embryo cryopreservation, oocyte cryopreservation, and the other techniques, if you see the live birth rates are best with oocyte cryopreservation, and they keep on reducing for all the other methodology. So oocyte cryopreservation is a method of choice for these patients, and embryo cryopreservation is even more widely available and long established. The oocyte tissue cryopreservation is important if there is insufficient time to go or indication to go through the ovarian stimulation. When do you want to advise a patient for fertility preservation? Is best to freeze the eggs for social reasons before they turn 37. If we apply that our women age 6 years faster, then probably you can do the math that in early 30s is when they should freeze if they're really keen on having their biological child. And of course, before any form of chemotherapy or radiation is initiated, always note the AMH of women. This was something that oncology has missed a lot. They were relying on FSH levels, and we have realized that FSH levels may denote the return of menstrual function, but it does not denote the return of fertility. So looking at very quickly the effect of chemotherapy, follicular apoptosis, activation of primordial follicles, and vascularization impairment, all of this reduces the number of follicles available and increases the follicular apoptosis. Gonadotoxic therapy, pelvic therapy, surgery, or endocrine therapy, all of this somewhere or other will reduce the number and cause ovarian aging, and that leads to ovarian insufficiency. So counseling is something very important in oncofertility patients. You have to note how keen is their interest in fertility. If they're only keen in ovarian function, then yes, they can think about GnRH agonist. But if they are also keen in fertility preservation, then they have to go through the process. And it is, as per Eshrey, it should be a multidisciplinary approach where we talk to the clinical side, the counseling side, and aftercare, and support the patient throughout their journey. There are some topics that we have to address as clinicians. We have to explain to them the impact of cancer on their treatment or reproductive function, impact of cancer on their treatment for fertility, the options of fertility preservation, the issues related to cryopreservation after fertility preservation, fertility treatments and options available once they freeze their eggs, pregnancy chances after the therapy, and childbearing and parenting options other than this have to be discussed. We have to evaluate the patient's intrinsic health and also extrinsic health, whether they are able to afford this, how is the risk of primary ovarian insufficiency for this patient, and how's the uterine health going to be once she comes back to utilize these eggs. Safety measures and stimulation protocols is the most important thing that everybody is looking at and asking about, and hence there are widespread guidelines by now. So if we are stimulating women for fertility preservation, GnRH antagonist protocol is recommended, which is short time and safety reason. For patients requiring stimulation where there's a lack of urgency, we can use also a long protocol in some patients. But in urgent FP cycles, random start ovarian stimulation has become the norm. Double stimulation is also an option. And use of in ovarian stimulation for fertility preservation, estrogen-sensitive disease, the use of anti-estrogen therapy like letrozole is recommended. And oocyte cryopreservation should be offered as an established method of fertility preservation. Even women with partners, and I have this talk with most of my patients, even if they are together, if they have been married, I always give them an option to freeze their eggs, because this is their choice to keep those unfertilized eggs for future fertility. And once we have made embryos, then it's going to be a sperm which has been used of their partner, and it will depend after 5 to 10 years when she comes back whether or not they are together to utilize those embryos. Use of GnRH agonists, there's been a lot of focus on this, especially from the oncologist side, where they are very keen to give them an agonist. And it could be an option for fertility preservation, but there are limited evidences, and especially with women with breast cancer, GnRH agonists during chemotherapy should not be considered as an option for fertility preservation instead of cryopreservation techniques, because it's not very efficient. And it may be considered as an option for ovarian function protection, not for fertility preservation. Now, looking at controlled ovarian stimulation, we have to, like I already said, do a thorough counseling, stimulation protocol, explain to them the comparison of outcomes, make sure there's risk mitigation, make sure their special scenarios are looked into. Assuring and convincing the medical community becomes a big challenge, and then comes assuring and convincing the patients about the safety of fertility preservation. So counseling should be initiated beforehand. It should be offered to the patient and explained that she's been given fertility preservation option because she has a good chance of survival, and that itself has a positive connotation for them. And it has to be explained to them that cancers itself may be able to reduce their fertility potential even before the chemotherapy has been started for these patients. A meta-analysis when comparing number of oocytes retrieved in cancer groups to control groups clearly shows this, that cancellations were higher and retrievals were slightly lower in cancer patients already. So these patients already have a declining oocyte quality, and they may be at a negative aspect to do fertility preservation. And they have to know that frozen oocytes will be used by IVF at a later stage, and the need for transvaginal scan and consents for vaginal intervention, especially in younger women, is very, very important. So before we start stimulation, it is important to make sure that patient is hemodynamically stable, to clearly discuss with the oncology team the time taken from initiation to egg retrieval, make sure there is prevention of OHSS. Effect of high estrogen levels should be discussed, and post egg retrieval recovery so that she can proceed to chemotherapy without further delay is very important. Ovarian reserve testing is important for these patients so that they can understand what is their basal FSH, what is their AMH, and antral follicle count. This helps you to plan a robust stimulation, because you have to know this is the only window that she has, and most of these patients need slightly higher dose than the regular patients. So we cannot think about doing a mild stimulation for these patients at any point. And personalization is important. Conventional start may need a little bit longer time, so it's not a viable option for these patients. Development of antagonist cycle, which is the maximum number of cycles that is happening now, is important to make sure that we use that. And this allows for agonist triggers and decreases the chances of ovarian hyperstimulation. So the concept of random start comes from the fact that we know there are follicular recruitment waves in the ovaries, and we can start stimulation at different times. Of course, the follicular time, then also its late follicular phase, and luteal phase stimulations can also be tried for patients. So random start protocols are very attractive, especially for this group. If you see the patient around the menses days, check the baseline hormones and start stimulation. If you see them post-ovulation, check progesterone to make sure she's ovulated and start stimulation. And if you see her just before ovulation, induce ovulation, and then you can start stimulation so that you don't lose any time. So this is random start. Sorry. So random start, if the follicle, it would start if the follicle cohort was less than 12 mm, and after the spontaneous surge, GnRH antagonist was added when cohort reached 12 mm, around day 5 or 6 of stimulation. If the follicle cohort following the lead follicle reaches 12 mm before the surge, suppression with the antagonist was initiated, and the surge was given as planned earlier. Luteal phase start is very simple. You see the patient after she has ovulated and you start the stimulation for her. Looking at the comparison in random start versus conventional start, it showed similar average number of aspirate oocyte, and it was seen definitely that the number of M2s and fertilization was similar. The only thing was the random start patients required slightly higher gonadotropin dosage and little longer stimulation. So you can see the days of stimulation was slightly higher, 2 days, and the total dose was also slightly higher for these patients. Again, the similar data from different studies. So specific protocols for controlled ovarian stimulations, and there were specific concerns that we have for these patients. We know there is going to be a supraphysiological estrogen level resulting from a higher stimulation, and that's why we have to make sure that we use for patients with estrogen sensitive tumors and such patients. Natural cycle is not an option because it gives very few number of eggs. Tamoxifen has been known anti-estrogenic, and it's been used to compete with the antagonism of estrogen. And also it has been seen that it leads to increase in GnRH secretion from hypothalamus. Peak E2 levels in stimulation with tamoxifen are not altered because of its anti-estrogen effect. It's desirable to be used in estrogen-positive breast cancer patients. And letrozole is another agent which can be used, which is aromatase inhibitor. It inhibits the aromatase activity, reduces the estrogen level, pushes the FSH level higher, and makes sure that these patients, in fact, were seen to have much lower E2 levels. They needed little shorter stimulation, and there was no effect at all on the quality of eggs or the embryos formed from these prevention. Looking at the prevention of OHSS, now we know OHSS is mainly due to higher estrogen levels, so we use letrozole there. We know there are higher oocyte numbers, so this is a necessary evil to give fertility preservation a good chance, and you can always suppress her immediately after egg pickup. And of course, pregnancy and stimulation causes OHSS. This is not a case for these patients. The last thing is about HCG trigger. And hence, HCG trigger can be replaced by GnRH agonist trigger, and it's safer, reduces the chances of OHSS, and it causes a good surge, which is FSH and LH surge, and helps with the oocyte qualities. And the only thing is when people feel that we didn't get a good yield from agonist trigger is you have to give antagonist a washout period before you give your agonist trigger. That's the most important thing which is being missed. As long as your antagonist is washed out, the molecule will bind to the receptors and give a proper surge and ensure there's a right amount of egg retrieval. In case you want, you can do after 12 hours an LH level to see if the surge has been achieved or not, and if not, you can add some amount of HCG, which will not really deter from the patient's outcomes. Patients undergoing COS are at increased risk of thromboembolic events because of hypercoagulable states. So for these patients, you can start low molecular weight heparin if you see PCV is more than 40 and stop 24 hours prior to the egg pickup and start after that. Malignancies, especially with bone marrow infiltration, etc., may have a tendency towards bleeding, and here we have to be ready to support the coagulation system by platelets or fresh frozen plasma. There is a slightly higher risk of pelvic infection after oocyte retrieval, and these patients, we should monitor their absolute neutrophil count to make sure their safety, and anesthesia consultation should be done prior to these patients starting treatment. For cervical cancer patients, make sure that fornices are free and the process of ovum pickup itself does not disturb the cervical mass, and be prepared because these masses can bleed like crazy. There are some new protective advances and agents, and we know about these agents, and we are saying these anti-apoptotic properties. Whether they will be able to preserve these oocytes and to activate the follicular pathway is yet to be seen. There's talks about engineered artificial ovary, which will be able to have a 3D matrix and support scaffolding of primordial follicles. Stem cell, the use of primordial follicles, but in spite of all these advances, to date, there are no proven stem cell-based means to improve reproductive functions in any of the patients, so that's something we have to keep in mind. Beside oocyte cryopreservation, there's option of IVM for those patients where you would not like them to be stimulated, and this has lesser live birth, but we have successfully done IVM in our labs, and of course, this is the right type of patient that you could do it when you cannot do stimulation. Ovarian tissue cryopreservation is important in prepubertal patients, but these patients will need two surgeries, one to remove the cervical cortex strip, the ovarian cortex strip, and second will be to reimplant them later. And that small risk of reintroducing the cancer cells is high in some group of patients, and that's why intense testing with immune histochemistry should be done before we do this repositioning. The summation from our learning today is that modern treatment for breast cancers have improved the cure rate. When these patients are alive, they want good quality of life, which is also their reproductive potential, and hence our gearing up is very, very important for fertility preservation. And outcomes have been very, very promising, and this is the reason why we are talking so much about it. Data confirms that we can make it safer for them, reduce the E2 levels, not give them HCG trigger, and still have good number of eggs or embryos frozen for them. PPO's protocols have been proven to be equally effective in antagonist protocols, and they have the similar amount of fertilization, similar amount of retrieval, and blastocyst formation. And there's studies from Professor Barris, and also we did a small study in our center to see the same outcomes. And pre-implantation genetic testing for monogenic disorders is something which can improve the progeny for these patients, especially for BRCA-positive and Lynch syndrome. So FIGO recently in July 25 has put out some best practices for newer agents used in oncology, like immune checkpoint inhibitors, and we do not know how is the effect of them, but these are the newer drugs on the horizon which will be playing out the market. The small molecule inhibiting target oncogenic pathways, epidermal growth factors, monoclonal antibodies, etc. These are contraindicated in pregnancy, but their data on preserving the oocytes is still limited. However, the safe washout periods for many of these agents before conception remains starkly undefined, and that's where further research should be. Never give up on a dream just because of the time it will take to accomplish. Thank you so much. And if you would like to be a part of Fertility Preservation Society of India, you can click this slide and be in touch and register for that. I thank you for your patient listening. Thanks.
Thank you for this incredible talk, madam. Everything regarding fertility preservation is beautifully covered. I have a question, ma'am. Since you said that oocyte cryopreservation is preferred over embryo, how are the aneuploidy rates post-oocyte preservation when compared to direct embryo freezing?
So aneuploidy is not caused by oocyte freezing is what we have to remember. The aneuploidy is caused by the inherent factors of the gametes, age of the woman. And if you have this idea that this woman was older and she maybe had higher risk for aneuploidy, you can counsel them that when she does come back to form her embryos, PGTA, pre-implantation genetic testing for aneuploidy should be an option for her because she was older when we froze her eggs or any of those parameters. But to date, we don't have any data which says that freezing the oocytes causes more aneuploidy.
Okay, ma'am. Thank you so much, ma'am.
Excuse me, Dr. Richa. Another question. Recently, 24 years unmarried lady came to the OPD to freeze her eggs because she is working for NASA. So another 10 years she is not coming back. So like legally anything like we have restrictions about the age or
44 you said? 44 or 34?
24.
24. Of course, there's no legal age where you cannot freeze the eggs. The ART law only says that you should offer any ART procedures for the women in the age group of 21 to 50 years. However, having said that, we had a patient who is 18 and is being diagnosed with a cancer. We were able to freeze her eggs still, in spite of all these limitations, because we took all the steps, took the medical opinion, took the legal opinion, and made sure that because this is the only chance she has. For a 24-year-old, if you feel that she's not the right candidate, do an AMH. Let her see an antral follicle count, guide her that she's in a good fertility potential right now, and if she feels that she will not be able to plan a pregnancy till she's 30 plus, then she should freeze eggs now. If she feels that within the next 10 years she will be able to plan fertility, then that's probably not really needed for her. But if it's her choice to freeze the eggs, there's nothing in the law which suggests against it.
So anything like guardians or parents' consent is needed for her because
24 is, she's an adult.
major.
Yes.
So she can go.
Yes, of course.
Individually,
of course.
she can take. This.
Above 21, they do not need any guardian's consent or approval. But below that, if for fertility preservation reason, please make sure that you have a psychological counseling, you have a legal opinion before you start the procedure when they are less than legal age.
What is the blastulation rate from the frozen usage when compared to the fresh usage?
So there's lovely information from EV group, Anna Kobo. They showed that when the woman whose eggs were frozen was less than 37 years of age, there was no difference in the blastulation rate between the frozen oocytes and the fresh oocytes. The things change after 37 years of age because of the, we know that more and more aneuploidies happen in that age group and egg reserve declines. But it does not impact, in fact, before the ART law came in, we were freezing oocytes to use for women who wanted a donor pool. In fact, in Spain, frozen oocytes from donors are being used for the purpose of donor gamete utilization. So the data is coming from that group, which is good fertility potential patients. And we see if the fertility potential is good, it does not impact the blastulation rate.
Thank you, ma'am.
Thank you.
Thanks a lot.
Thank you so much.